So they generally included high-risk patients. They were not designed specifically to look at that group, so they're always a subset of patients, but they did include them. And I'll clarify, that was a French study, so not my study per se. That's okay. I don't want to take credit for their work. So no, the reason they did that honestly was to keep the patients sort of on time. So in other words, the other arm got 8 cycles of VRD, and the arm that got transplant got VRD for 3 cycles and a transplant, and they were finishing up earlier, and so they added 2 more cycles on the back end just to sort of even it out. So it was really 5 cycles of VRD plus transplant, or 8 cycles of VRD, and that was the reason for it. I agree. We don't always do the consolidation, the treatment after transplant, but that's commonly done in Europe, which I think was one of the reasons why it was designed that way, to try to keep them even. Do you want to comment?
I just want to add, so the concepts of induction, transplant, consolidation, and maintenance actually came from the University of Arkansas, not Europe. They were adapted from the leukemia world into the myeloma world by my mentor, Dr. Barlogi, who started the Total Therapy program. And the original concept of consolidation was when you did not have active induction chemotherapies, you would be collecting stem cells from a patient who still had a lot of myeloma burden. So the concept of consolidation after the autologous stem cell transplant was to give additional therapy to cytoreduce the disease further. So that's where the concept came from. Yeah, thank you.
Yeah, in the context of the IFM study, everybody got those 3 cycles of treatment and then went on to stem cell collection. They didn't have the choice to give 3 cycles versus 4 cycles versus 6 cycles, which is why it was designed in the way that it was. But given the fact that we typically use our induction therapy to best deep response, we think that the data from the IFM study can be easily extrapolated into how we practice, myeloma therapy in the U.S. Generally speaking, patients who have these bone lesions identified on PET imaging have more aggressive disease biology to begin with. So presumably, if you were to do 2 random samples in a patient who did not have focal bone lesions, you probably would see less discordance in that particular situation than in somebody who has a focal lesion. And I want to be clear here, I'm not necessarily advocating, as Dr. Usmani was joking about earlier, that we start sticking needles in every single thing that lights up on a PET scan. I mean, that would be sheer torture. The point is, at least, for those of us that treat myeloma all the time, we oftentimes, well, I shouldn't say oftentimes, but occasionally we're surprised. A patient who, for all intents and purposes, appears to be a standard risk patient, they've gone through their induction, their transplant, they're on maintenance therapy, and a year later their disease is already progressing. Why did that happen? And I think, this may be one of the reasons why that's happening, because we are underappreciating the presence of high-risk disease in these particular patients. I think that the liquid biopsy technology, the cell-free DNA sequencing, as it becomes increasingly sensitive and reliable, that would be a tremendous way to be able to look for those high-risk markers. Because the nice thing is, regardless of where the lesion is in the biopsy or in the body, regardless, whether it's just diffuse marrow infiltration or multiple focal bone lesions, as myeloma cells grow, they die, and they release DNA into the circulation, and it all gets mixed in, and you can identify the high-risk lesions regardless of where they are initially originated from.
So the answer is yes. Who's next? So we have the same group of investigators who are, members of the International Myeloma Working Group. We have, the same investigators who are working together within the Multiple Myeloma Research Consortium. And I think myeloma crowd kind of falls in that category as well. So there are only 250 odd myeloma experts in the world, according to the International Myeloma Working Group. All of us know each other well and collaborate on different things. I think each of these organizations have a different focus. And so, our job is to collaborate and contribute, to the field as a collective. And we are, our research community is actually more cohesive and does more collaborative work with, compared to some of the other disease subsets. So we don't have a lot of big egos or personalities here. At Adam and our center, we are working on several early phase clinical trials together. And if there are clinical trials that we don't have and are there at Penn, we would refer patients to Adam, and we actually have at least one person here who's an example of that. We saw them earlier. You want to add something?
There's a very strong, the National Cancer Institute recognizes this issue, and just given the complexity of the disease, I think everyone recognizes that we need to partner together and bring our databases together to better understand how to treat these very select subsets of patients with very unique disease biology. Because most of the studies that we're going to show you today are the exact same treatment regimen regardless of what your cytogenetic background is. So I think that the NCI recognizes that. A lot of these genetic databases, whole genome sequencing, whole exome sequencing, RNA-seq, et cetera, gene expression profiling, all of that gets uploaded, into where it can be accessible to a variety of different investigators throughout the world, actually. So it's happening increasingly. I think another big challenge is that what we see reported in clinical trials is not necessarily representative of how patients do with these various therapies in the real world. Clinical trials are designed very carefully. Eligibility criteria are constructed, in a very laborious way, and I think people are increasingly recognizing that perhaps in an unfair way, we need to loosen those eligibility criteria so we can better understand how these things are really performing in the real world. But the initiative that Jenny talked about, at the beginning of the presentation, as far as allowing patients to enter in their data and what they've been treated with and how they've responded, things like that will allow us to get a better handle on, how all of this is performing in the real world.
I think, again, we are in the Myeloma Crowd platform, but I do want to highlight one example about, how clinical and genomic data is being shared. When I was in Arkansas, we did very comprehensive gene expression profiling on thousands and thousands of patients. And when we published those papers, only a subset of data was released to the public or made publicly available. I think the MMRF COMPASS trial was a fantastic experiment of generating comprehensive genomic data on over 1,000 myeloma patients, and then making that data set available to everyone. So it doesn't matter if you participated as an investigator in that study or not. You had access to that genomic data, and they could, you could publish on that data, interrogate it the way that you want to. I think it's been a fantastic experience. I think at last 2 years at ASH, there were over 50 abstracts presented from the COMPASS data set, and only, I think, a third of them were from the MMRF investigators. The rest were from non-MMRF investigators. And that's how collaborative science should be. Yep.
Yeah, I will say, just editorially working on this for 20 years, the collaboration amongst the researchers on both sides of the Atlantic and the Pacific is actually very, very, very good.
Very simple question, thank you. So what are the pros and cons? I guess the cons, I guess, are if there is active myeloma there, which we think there may still be in microscopic levels in a lot of patients, when you stop the maintenance, you may get a chance for that to grow back. And then the pros would be that you get a break from treatment for a little while, and the side effects of treatment. So that's the concept of a treatment holiday, which again I think was used more in cancer when we had more toxic chemotherapy drugs, and patients really couldn't stay on the chemo drugs for very long, and they would take a break, and then you would restart therapy. I think in myeloma, and my colleagues can comment on this as well, but the concept of more continuous therapy is really what we're trying to do. I think you need to suppress those bad clones and not give them a chance to start to escape and grow back. And so that's the risk you take when you come off. Obviously, if there's been bad side effects or severe infection or something else, we always take breaks. But we do try to get patients back on rather than stopping and starting. At least that's been my practice.
Yeah, again, in the real world, there are, patients who don't tolerate Revlimid maintenance therapy well. They might have, problems with excessively low white blood cell count, making them more vulnerable to infection. They may have highly problematic diarrhea, fatigue, muscle cramping, rash, you name it. So there are scenarios where we do have to modify the originally planned schedule of administration to allow patients to be able to tolerate therapy better. But under the best of circumstances, when the therapy is well tolerated, I completely agree with Adam. I think most of us here would agree that it's probably better than lenalidomide. So this is, kind of the practical issues that occur when a single drug company is making, more than one drug for a specific disease. So Celgene, developed Revlimid first, and Pomalyst on its heels, and the Revlimid trials, were moved to frontline therapy quite early in the game. So they kind of just, as a company, to allow both of their drugs to prosper, kind of, used Revlimid in the frontline trials and used Pomalyst in the, relapse studies. And that's kind of how it's evolved over time. They didn't want Pomalyst to cannibalize Revlimid. So, but if, in an ideal world, if we were to use, any IMiD we wanted to in the frontline setting, I think Pomalyst might be a better choice, actually. Because there's clear evidence that Pomalyst can work in Revlimid-resistant disease, but the reverse is not necessarily true.
Sure. So I think right now a lot of the CAR studies are excluding patients with prior allo transplant. That's the way they've been designed by the companies. Not all of them. Our study, for instance, at Penn didn't. But my hope is, as there's more safety data that emerges with the CARs, that they start to loosen those restrictions a little bit, and that eventually that won't be an exclusion. Certainly in other diseases like ALL, where CARs are used, a lot of patients had prior allo, and there was not excess risk in those patients who got a CAR. But right now it can be tough to get on.
All right, so I'm going to give you a very general etiology explanation. Any disease that has inherent genetic predisposition tends to occur earlier in life rather than later in life. That's a general rule. There are exceptions there as well. There are some diseases that manifest in the third, fourth, or fifth decade of life. But individuals are born with those genetic abnormalities. For the most part, myeloma is not a genetically driven disease, or an inherited disease. But there are studies that highlight individuals who may have had similar exposures growing up. If their immune genetic makeup is similar, the likelihood of developing, an MGUS condition or another condition would be higher than the general population. And I'm speaking in hypotheticals because, if we look at, GWAS studies looking at SNPs and things, we really haven't identified a pattern of predisposition. But, it's quite possible that, that siblings growing up, on a farm exposed to pesticides, for the first 2 decades of their life, even if they move away to different areas, those exposures were enough in, creating an antigenic stimulation that leads to a plasma cell proliferation and eventually, development of MGUS and myeloma. We don't know the answer to that question, but that's a possibility. There are a couple of examples. There was a study in early 2000s looking at H. pylori infection in the stomach. And patients, I think about a fourth of patients with H. pylori in that study had a small MGUS MGUS protein present. And once they were treated for their H. pylori, more than half of the patients had the MGUS disappear. So there is some evidence of this antigenic stimulation leading to plasma cell proliferation and then eventually predisposing to myeloma down the line. What was your second question? No, I knew your question. I just wanted to hear cannabis one more time. I think that's a general question, not limited to myeloma, but all cancers. There are data highlighting modest activity in preclinical studies as well as in mouse models and maybe even some observational studies. My official stance is there's no harm. So what the heck?
The problem with the preclinical studies in multiple myeloma, whether you're looking at the active ingredient of cannabis or some of these other supplements that are tested in preclinical models, when you take myeloma cell lines in a petri dish and grow them, they're incredibly easy to kill, actually. You can throw just about anything on them and they die. And that doesn't, so the vast majority of agents, whether it's the active ingredient of cannabis or a chemotherapeutic or an antibody or what have you, while it looks great, against myeloma cells, when they go to the clinic in phase 1-2 studies in patients, they wind up failing. And a lot of it is that the preclinical models, at least in days gone by, weren't robust enough. That's getting better, so the current preclinical models are probably a bit more predictive of what's going to occur in patients, but they're still far from perfect. So there's really no robust data that cannabis has any activity in multiple myeloma, and there's reasonable anecdotal evidence that it helps with appetite, it helps with nausea, symptoms of the disease, for some patients, but not much in the way of data that it's active.
And I would just add, the same is true for curcumin and turmeric and things of that nature. There are preclinical, data, showing that there might be some anti-cancer activity. But for those patients who've already heard this joke, I apologize, but my people have been using turmeric and curcumin in cooking for centuries, and they still get cancer. So highlighting the fact that it's good for taste. I don't mind if you use it in cooking and all, but taking mega doses of some of these may not necessarily bring about an improvement in survival outcomes. So it might be a fad or something. Just bear that in mind.
Sure. So the gene expression profiling that I was talking about before is really just looking at the level of expression of specific genes. It doesn't take into account the mutations at all. So you're not getting a mutational assessment of the disease with gene expression profiling. There's a lot of interest in RNA-seq, for testing, because you can determine the level of expression. You can determine whether there's mutations there. You can look for the translocation, so you can get a lot of information. The one thing that you don't get with RNA-seq, next generation RNA sequencing, is that you don't get the mutations that are in the non-coding regions of DNA, which can influence expression. So there's pros and cons to the various types of tests, and I think that's why the COMPASS study is so powerful, because it's doing a lot of these different things in parallel, so we can look at patient outcomes, because they're getting clinical data as well, and determine which of these very powerful genetic strategies are the most useful clinically for patients and their physicians.
So in an ideal situation, you should be able to get the molecular subgroup of myeloma by the gene expression. The technique could be RNA sequencing, and then you will also get information about the mutational abnormalities, The gene expression profiling can actually give you a virtual karyotype as well for the patient. So in the current Multiple Myeloma Research Foundation molecular profiling protocol that we're following, when we get the report, we get all of that information on a single page. And that's eventually where you want to go. But we're not there yet. That these technologies are have some overlap, and we need to develop a cohesive way of doing all of these analyses with the least amount of techniques. So, it will probably be a combination of RNA and DNA sequencing, but we're still evaluating those profiling profiles right now.
Yeah, so those subgroup analyses were actually done in most of the big maintenance trials, and what they found was that regardless of how deep your response was after transplant, there was still a benefit of the maintenance seen in all the groups. So even if you were in a complete remission after transplant, if you got maintenance, you still did better than patients in a complete remission who didn't. And the same was true if it was VGPR or PR. So we don't think, at least based on those types of tests, that should determine whether you go on maintenance or not. Now, we have better testing now, as you've heard, with minimal residual disease testing that's more sensitive, and maybe that will, again, help determine who needs maintenance or who doesn't. But at this point, we still offer it to all patients regardless of depth of response, because there seemed to be a benefit in all the groups tested.
One thing I want you all to take home, though, is this, that we've talked a lot about depth of response. We've talked about achieving complete response, MRD negativity, et cetera. But a lot of the data, where CR was shown to be associated with better progression-free and overall survival, were done in days where patients were treated with a defined course of therapy, and then that treatment was stopped. So, in an era where we're using Revlimid maintenance, for example, as long as the patient's tolerating it, that is, until disease progression, does that still hold true? And I don't think that we fully know the answer to that question yet. The other thing is that there are molecular subtypes with indolent disease, better behaved disease biology, who may not need to achieve a complete response. There's very good data from the University of Arkansas a number of years ago now that patients who had MGUS, or a solitary plasmacytoma of bone, in the lead up to their diagnosis of active multiple myeloma, more often than not, they didn't go into complete response, but they did better than just about anybody. And then when you look at the gene expression profiling molecular subgroups, the CD2 group, this is dysregulation of cyclin D2, they oftentimes don't go into complete response, yet they go on and on and on, and they live for years. So it's a very heterogeneous disease, so we always have to be careful about how we phrase these things.
So, yeah, I think one of the big caveats with MRD testing, we might get to a point where we have such effective therapies that we're getting, most of our patients into MRD negativity. But the question is whether it's really necessary for certain subgroups like the CD2 molecular subgroup. When we looked at the Arkansas experience, our 20-plus year survivors, there were patients with the CD2 molecular subgroup that still had an M spike of 0.2 or 0.3 after they had received their primary therapy. They're still cruising. They haven't relapsed. But we know that there may be in an MGUS state, and that's why they have that M spike present. But it had no bearing on their survival and outcome. So the real question is there a subgroup of patients where you don't need that level of depth of response, and patients will still continue to do fine?
And just to sort of echo that point, there's a nice study from the Spanish group that if you actually reconstitute sort of normal B-cell immunity early on after transplant, that group is associated with sort of long-term disease-free survival, even if you have active myeloma. So there may be some interplay between the immune system and the cancer, and if you get robust immune reconstitution, that may actually help keep that disease in check, even if it's still present. So there's still a lot we need to understand, I think. So yes, a second or salvage stem cell transplant is definitely an option for patients if they're still eligible for it at that time. And this actually has been shown in a recent randomized trial where doing a second transplant seemed to lead to better outcomes to putting patients on sort of old-fashioned chemotherapy regimen. I think when we choose to do that is becoming a little bit more difficult because we have so many other options nowadays. But typically, if patients got a really nice long remission from the first transplant, then that's the setting where we'd think about a second transplant. Because often the time in remission after the second roughly is maybe half as long as the first. So if you were able to get 5 or 6 years from your first transplant, it might be worth doing that again. If you only got a year or 18 months from the first transplant before it came back, it may not be as helpful the second time. And that's one way we help choose.
So, there's definitely a lot of interest in consolidation maintenance strategies after allogeneic stem cell transplantation, because the challenge that we have with allogeneic stem cell transplant and multiple myeloma is that it takes a while for the new immune system to kind of become functional. So if the disease, starts to grow during that period of time, it might grow unchecked. So, there's a lot of interest in keeping the disease in check while the new immune system matures and is able to keep the disease in check, as Adam was alluding to. There was some early data with Revlimid maintenance therapy. Unfortunately, at least in one of the studies, it appeared that it might, kind of spur on graft versus host disease issues just because of its immune stimulatory effects. There's been a lot of interest in proteasome inhibitors, velcade, for example, as maintenance therapy after allogeneic stem cell transplant, and that seems to be very well tolerated and does not increase the risk of graft versus host disease. There's an ongoing CTN, this is a bone marrow transplant cooperative group in the U.S., which is employing an Enlaro and Ixazomib-based strategy for maintenance therapy after recovery from allogeneic stem cell transplant. So there's a great deal of interest, but I would say that the proteasome inhibitors appear to be the better tolerated maintenance strategy in that setting.
I think, so in general, the concept with an allogeneic stem cell transplant is very different from an autologous stem cell transplant. Here you're relying on someone else's immune system to suppress and eradicate the myeloma. So you're relying on graft versus myeloma effect. So the role of maintenance, for allogeneic stem cell transplant is not that well defined. We don't do this for lymphoma patients or leukemia patients. That's the concept. The issue is, there isn't as robust data favoring graft versus myeloma effect as there is for leukemia or lymphoma. So if patients do have residual disease, that's the reason why we're trying to, incorporate maintenance treatment. Ideally, you shouldn't need any maintenance if the allo was really working for myeloma.
Yeah, so maybe I wasn't clear. So there were, on that last slide where I listed all of the trials going on, the first 3 used Revlimid and Dex as the comparator arm, but those are already accrued. Those are older studies. We're waiting for readouts. All of the other studies use a triplet as the comparator, either VRD or KRD. And so I really do think either arm, whichever you get on, you will be getting an active triplet. There's really almost no study going forward that I'm aware of where they're using doublets as the comparator, as the control arm.